Okay, so as we finish our poster sessions for today, we will now resume for our afternoon scientific sessions. Once again, we kindly invite the moderators and speakers to proceed as scheduled.
Ladies and gentlemen, we will now continue with the topic Legacy of Disease, How Periodontitis Treats the Path to Peri-implantitis.
We would like to welcome Professor Dr. Sharida Hasnur Safi from University Malaya as our distinguished speaker for this session. The session will be moderated by Dr. Natalina, DDS, MDS, Periodontitis Consultant, PhD from Universitas Indonesia.
Okay, good afternoon all. So I think after lunch break, I think a lot of people doesn't come back here yet. Yeah, okay, but the time is very tight, so we begin the afternoon session. Distinguished guests, professors, doctors, and beloved college, we will remain enthusiastic after lunch break. Yeah, we continue with the presentation session by Professor Safrida Hasnur Safi session. But allow me to give some bio data or CV from Professor Safrida. Okay. She is a distinguished academic and clinician specialized in the periodontology and obtained her degree in dentistry from University Kebangsaan Malaysia in 2002 and served as dental officer in the Minister of Health Malaya in Kuantan, Pahang for 4 years. In 2006, she joined the University Malaya as a tutor and later pursued her master degree in clinical dentistry and periodontology at King College London and completing in 2009. And then the same year she awarded the membership of the restorative dentistry from the Royal College of Surgeons of Edinburgh and achieved her PhD in the University of Otago, New Zealand in 2018, focusing on the periodontal research, and then currently serve as a professor at the Faculty of Dentistry, University of Malaya, where she is also the Deputy Dean in the Clinical Services. And her academic role, she teaches undergraduate dental student and supervises the postgraduate student enrolled in the Master of Clinical Dentistry, Master of Dental Science, and PhD program. So I think she holds a position as an editorial board member of Biomed Central Oral Health, and a membership of national and international organization, and also a lot of publication in the national, international. It's a lot of publication there, so I don't state it one of one. Okay, and her topics to this afternoon is legacy of disease, how periodontitis treat the path of peri-implantitis. The stage is yours, Professor Sharida. Okay.
Thank you so much, Madam Chairperson, for your very kind introduction. Hello, everyone. Assalamualaikum warahmatullahi wabarakatuh, and very good afternoon. Okay, so I would like to extend my appreciation, especially to fellow colleagues in Universitas Indonesia, for a very warm welcome and also hospitality. Thank you so much. We truly appreciate that. Okay, let's move on to this lecture about how periodontitis become a risk factor for peri-implantitis. So before I begin, this is our team at University of Malaya, Faculty of Dentistry. We have actually 4 professors, and 1 associate prof, and 2 senior lecturers at the moment actively working at the department. Okay, so these are my team, and I believe Associate Prof. Zoraiza has introduced Faculty of Dentistry UM earlier on. Okay, so I will just move on. A little bit about, just to share with you what we have worked on, and also so basically I will navigate my talk according to this sequence, so don't worry if it's long. It's going to be very brief for each of these steps. Okay, so basically, just to start, what about dental implants? I think a lot of us are placing dental implants now, but it's not long since implant has been used as one of our treatment strategies. Okay, so in terms of scientific evidence, we only have got about 50 years worth of evidence so far. Okay, but in terms of the interventions, be it surgical or restorative, there's significant change that contributed to the economic impact. Okay, and we have seen a lot of implant systems. We have seen so much development in terms of new restorative solutions, and also technology advances in terms of digital planning as well as guided surgery. Okay, so in terms of how much implants being used or being applied by dentists, basically it's a lot, and it keeps on surging. Okay, and because it provides functional and also aesthetic benefits to over 1 million of people around the world. So let's talk about trends on dental implant use. So basically, we are saying that there's a lot of, there's increasing trends. Okay, so in the US, we see that the prevalence of dental implants being placed in adults rose from 0.7% in 2000, around 2000, to 5.7% in 2015 and 2016. And the projections that they made is it's going to go up even more, about 23% by 2026. How about Europe? So in terms of Europe, they haven't got like a statistic about that, but they're also saying that they predict that it's going to go up as well in Europe, and shifted towards fewer implants per patient, and widespread use of implants, okay, among dentists. In other parts of Asia, we see similar upward trends, and particularly in Malaysia. We have data from our Ministry of Health that shows increasing trends as well. There's a dip in 2020 because of COVID, but after that, the numbers start to pick up again. So these, increasing trends are driven by a few factors. One of it is aging population. Okay, as you can see that even in Malaysia, the life expectancy has increased from 63 many years ago to 77, about 77 years around this time. So, and we are seeing that even like, our Prime Minister, our former Prime Minister, Dr. Mahathir, is 100 years old now and still healthy and on the move and very strong. So, and I believe that in around Asian countries it will be the same as well, because access to healthcare is very good now, and also quality of medical services are very good. Other factors are improved implant technologies, yeah? And I would think that even the prices are coming down, so it is affordable for people. Greater patient expectations as well, with access to knowledge and information in social media and so on. Then we see that they know about it, and they see that this is something that I want. And then, of course, desire for enhanced quality of life. Okay? So when new challenges emerge due to increasing trends of dental implant placement, implants, and we also know that implants are being placed by many of us, be it specialists, OMFS specialists, periodontists, prosthodontists, and even general dental practitioners. And to be honest, because the training are different, so they have different approaches in terms of placing implants. So there will be some variation in terms of principles behind placing implants. So that's why it becomes like a challenge. I would like to focus on the risk factors. I do not bother to explain about prevalence or incidence at this point because I think all of you know that peri-implantitis is a problem. And if we talk about prevalence because of the variation of the implant system, so the incidence and prevalence are also varies with one publication to another. As much as we know about risk factors for periodontitis, and as I mentioned earlier about, implants have just gone into our treatment about 50 years ago, so a lot of things we don't know about dental implants, and we're still, and peri-implantitis, so we are still learning about the risk factors. So this review by Professor Darby from University of Melbourne he has done a very nice review in Perio 2000, and he mentioned that established risk factors are history of periodontitis, smoking, and lack of maintenance care, whereas suggestive risk factors are diabetes, poor plug control, excess cement, implant location or design, and also lack of keratinized mucosa. But what I'm going to focus today is, as a periodontist, of course, very much likely, I'm very interested on history of periodontitis and how does that affect peri-implantitis incidence. Okay, so many years ago, about 15 years ago, I think, so we published a systematic review and meta-analysis where we, at that time, we've just got 6 studies to be accepted into the review. We conducted meta-analysis and we found that the survival rate for dental implants is 3 times more likely, favoring periodontally healthy patients compared to the periodontally compromised patients. And be in mind that the periodontally compromised patients in this group of people were those who have very good maintenance program. And then in terms of mean bone loss, so we found that there's a significant difference between periodontally compromised group and also periodontally healthy groups by 0.61 millimeter, which we see that more bone loss occur in periodontally compromised group. And then this is a much recent systematic review and meta-analysis. So this one was done by Serrano and colleagues published in 2024, and they also found that in terms of risk failure, there's 74% greater risk failure in periodontally compromised group compared to periodontally healthy patients. And when they look at studies that have followed up the patients for more than 5 years, they find that the risk failure was even greater, which is 126% greater in periodontally compromised group. And the weighted mean difference of marginal bone loss was quite similar to our study, our meta-analysis. We got 0.61 millimeter, and they found that it's 0.75 millimeter, favoring the periodontally compromised group. So we are very interested to find out why patients with history of periodontitis are at risk or susceptible to peri-implantitis. So we started, this is a very big project. It is a prospective study that we carried out, whereby we look at this, we have a periodontally healthy group and periodontally compromised group. And we place two types of implants in this group. One is I wouldn't say the brand, but it's just the surface characteristics. So we have one group is a roughened surface, and then the other group is moderately rough surface, because nowadays we haven't got any smooth surface anymore, right? Okay. So in this publication that we have done, we were only looking at the supragingival microbiome, the transition following implant placement. Okay. So we investigated and we followed up. Sorry about this. So we followed up the patient. If you look at if tooth A or tooth B, implant A or implant B, means A is the roughened surface, whereby B is referring to the moderately rough surface. So we look at the adjacent tooth as well as the implants, and we followed it up for, in this case, up to 3 months. So V1 is baseline, V4 is the implant placement. So V6 is during crown installation, and V8 is 12 weeks or 3 months after loading or crown placement. So we follow this up, sample the supragingival biofilm, especially around the dentogingival areas, and And so we extracted the DNA and we run the NGS. Okay, I don't bother to go back. So we got the heat map, and then these are the big bacteria that you see. So basically, that color coded to the heat map. Okay, and we've got gram positive as well as gram negative there. But we will look at this more carefully after this, so that you can understand what's happening around the implants and the adjacent teeth. So for the beta diversity, basically you are trying to see the transition or the difference between the microbiome in the periodontally healthy group and periodontally compromised group. So the first, sorry, it keeps going like that, but anyway, so we will just go with this one. So this is the graph that shows the difference between the roughened surface implant with the moderately rough surface implants at 3 months post crown placement. Okay, and you see, and the difference in terms of the shift or clustering is significant in this case. And when we look further, sorry about this. Okay, so if you look at the, in terms of the dysbiosis, okay, so we want to look at whether gram positive, so the green bacteria is the gram positive and the orange bacteria are the gram negatives. And we can see the difference between the history of perio group and perio healthy group, whereby the dysbiosis starting to happen in the history of perio group 3 months after loading, okay. So, and this is just to show the difference within the group of implant with roughened surface from the implant installation to the 3 months after crown being placed. And similarly, we see the dysbiosis after the 3 months. Okay. The dysbiosis within the history of peri-implant group between the V6 and V8. Okay? And this is looking at teeth adjacent to the roughened surface implants. And similarly, we start to see the dysbiosis 3 months after implant have been, the crown have been installed on the implants. that is just what happens within the supragingival biofilm. And then after that, this is a work done by my PhD student, and she was looking at the inflammatory biomarkers around the implants, starting from the placement of the implants up to 1 year. So at this stage, she just have analyzed the MMP8 levels. So if you look at the graphs from baseline and then after so this is GCF, MMP8 in GCF of teeth adjacent to dental implants, and we can see that there's fluctuations. At first, at baselines, the MMP8 is quite high, but after that it went down, and then it's gone up high again at V8 and then starts to stabilize at V9. So the high levels of MMP8 that happens in V8 basically is just remodeling, but it starts to stabilize at V9, which is 1 year. And at the moment, we haven't seen any peri-implantitis happening or even mucositis. Okay, for the clavicular fluid or sulcular fluid around the dental implants, similarly, in terms of the trend, we see that at V8, which is still a remodeling because 3 months following implant placement, and then after that, at 1 year, it's start to taper off. So we have to still really look at, follow it up for another 3 or 5 years to really know what's happening. Okay, so let's have a look at a case. So I've got one case with a very complex management that has been carried out by one of our postgraduate in the clinic, just to put everything into perspective of how bad peri-implantitis can be and how difficult it is to manage it and to keep it stabilized. So this patient was, when she came, she was 74 years old, came in 2022. She's got hypertension and on amlodipine, hypercholesterolema and on simvastatin. So this is what she looks like when she came to see us. And then after that, so if you look at the probing depth, it's very, very deep, mostly in most of the implants. Okay, that's for upper teeth. This is for lower teeth, and you can have a look at the bone levels around the implants as well. It's very saucerization type kind of bone loss around the implants. Okay. So the diagnosis at this time were peri-implantitis of several teeth. She's got reversible pulpitis on 2.7. There's also secondary caries on 1.3. And this patient is partially dentate on maxillary and mandibular arches. So the treatments that we've carried out, there's a lot of treatment that we carried out for this patient. So basically, we've done 2 rounds of non-surgical debridement. We did resective surgery on 3.1. We did reconstructive surgery on 3.3 and 4.1. We did reconstructive surgery on 4.6, and also access flap surgery with implantoplasty, because some of these implants, even though we've done the surgery, 1 round is not enough to really stabilize everything. And then we did reconstructive surgery on 1.4, access flap surgery and implantoplasty on 3.3. And then after that, we put the patient on peri-implant maintenance therapy. So this is how she looks like now, just this month. Yeah, we just did the reassessment on her this month. So it took 3 years to do all the work for her. So basically, if you look at the difference in terms of the color changes of the peri-implant tissue especially, so in the end, we have managed to stabilize everything, achieve the endpoint treatment, but we still have got 1 implant, 4.6, that still have got 5 millimeter pocket. But if you look at the implant, it's not favorable at all, but patients still insist to keep it, so we just keep it and maintain it, even though the pocket is still 5 millimeter. The angulation also is not really good. So this is just to compare. So before and after, so you can see that a bit more pale pink presentation. around the peri-implant tissues after the treatment. So at this moment, everything is under control. So a lot of work, and you can imagine how much work and how much money that we have to put in terms of trying to stabilize this. So that's why I would like to stress that prevention of peri-implant diseases is very important, and that's why you have to address that risk factor that we know earlier before you start getting excited and want to place implants. Because at the end of the day, you want the implants to work in the mouth and not having to deal with this kind of complications, which can be a nightmare. Okay, so in terms of prevention, we have, I think the Heights, Mayfield, and Lang group, they have recommended a risk profile, just like periodontal risk assessment. So risk profile assessment that you can use, implant disease risk assessment. So it is based on 8 parameters: history of periodontitis, percentage of sites with POP, prevalence of pocket depth 5 millimeter and more, bone loss in relation to the patient's age, periodontitis susceptibility, supportive periodontal therapy, implant restorative depth, and also prosthesis-related factors. So these are the factors that you can consider, and you can map it. Okay, you can just plot it, and you get the spider web kind of diagram. So if it's high risk, then you know that it's high risk if at least 2 parameters in high risk category, okay? And if you look back, and then if it's a moderate risk, if at least 2 parameters in the moderate risk category, but at most 1 parameter in the high risk group category. So when you plot, you get that, then that will be moderate risk. For low risk, all parameters in the low risk categories, or at most only 1 parameter in the moderate risk category. Okay, so you know that, okay, in terms of risk, they are at this category, and then you can plan your interval, how frequent you need to see those patients in terms of maintaining their dental implants. So there's always a question about, how long, okay, how long do we need to get patients to come back for the maintenance. So this study by Monje in 2016, they found that reasonable interval for peri-implant maintenance therapy is every 5 to 6 months. And they see that lowest incidence ratio for peri-implantitis at patient and implant levels if you keep your patients at 5 to 6 months maintenance. And they also proved that implants that received this kind of maintenance therapy had 4.2% lower incidence of implant loss. So this is a very good suggestions or recommendations that we can follow in terms of maintaining our dental implant patients. And this is not just for periodontal patients, but for every patient if you must. Okay. And then the other thing is about the factors that. Okay, so we see here that there are a few factors that you can relate back to IDRA risk profile. So you see here plaque score more than 25%, okay, and then plaque index more than 1.5. Peri-implant mucositis, periodontitis, male sex, irregular compliance, these all have got that odds ratio at least 2. Okay? And they are significantly associated with incidence of peri-implantitis. And then so that is for overall, but if you see that if that group is well maintained, they are going through a regular maintenance, then there's only one factor that is significantly associated with incidence of peri-implantitis, which is peri-implant mucositis. But those people in the group of irregular maintenance, they have got plaque index. There are 4 factors from the total factors that are significantly associated with peri-implantitis. So be mindful that these are all very important. And the incidence or the odds ratio is quite high. So there's another a point about dental implant supportive care. So basically, for patients, these are the patients, this is to show that maintenance work and maintenance is able to control patients from developing periimplantitis. So this is patients with a history of periodontitis and they underwent SPT every 4 to 6 months and they have been followed up for 5 years. So within these patients, they see that the prevalence of periimplantitis is about 15% at patient level and 9.8% at implant level. So even though they are going through the SPT, they still get periimplantitis. However, nearly there? Okay. Okay, so periodontitis was significantly associated with peri-implant mucositis with odds ratio of 0.5, 0.5, sorry. So that's quite small odds. Plaque index 25% and more was significantly associated with peri-implantitis. So the odds is 5.6. That means patients who have plaque index 25% and more, they are 5.6 times more likely to develop periimplantitis. So 5 times more likely, that's very high. And they also found here that at least for the well-maintained group, periodontitis was not associated with periimplantitis. So that's good news for us to say that we have to maintain our patients so that we can keep the periimplantitis under control, especially for our perio patients. So in summary, what we can conclude is that an increasing trend in dental implant placement is expected to be accompanied by corresponding rise in peri-implant diseases. Okay, so the more people place implants, the more peri-implant diseases that we may expect. And then the second point is patients with a history of periodontitis exhibited supragingival biofilm microbial dysbiosis on their dental implant crowns compared to periodontally healthy individuals 3 months post-loading. Okay, so that's why it's very important to really maintain them, make sure that you do the prophylaxis, the supportive periodontal care for them. Regular implant maintenance therapy conducted 2 to 3 times annually has the potential to lower the risk of periimplantitis. So those are the take-home message from this presentation. I think that's all from me. Thank you so much.
Okay, thank you. It's very interesting presentation, Prof. Safrida. And then we can know that there is a risk factor for peri-implantitis. That's the thing that established is the history of periodontitis,
Yeah.
and then lack of the regular maintenance. And when again, I think I write it, but I cannot read it.
Yeah.
Sorry.
Those are established ones. Yes.
Yeah.
Yeah.
Okay. Yeah. And then we have to know about the implant disease risk assessment. It's from 8 of parameters. Yeah. So it's like a history of periodontitis, but there's some journal that it's from periodontitis. There's going to be a periimplantitis for the patient, yeah. But a lot of things that they still have hubungan there. So,
That's right.
Yeah, okay. And then, so I think we have time to have 1 or 2 questions from the audience. Please, if you have a question for the professor. Okay, yeah, please.
Good afternoon, Professor. Thank you for the insightful presentation. I just want to ask one question, maybe. In the MMP8 research that you've shown earlier, could I ask, is there another factors besides remodeling that affects the MMP levels in the periodontitis group? That because the V8 time is, the MMP8 is rise
High.
up, right?
Yeah.
Yes. But before the V8, it's going down, and after the V8, it's going down also.
That's
Is there
right.
another factors besides the remodeling?
We have IHC analysis as well, and we look at the biopsy because of the biopsy as well. So we are now at the moment, I mean, like because she's out, my PhD student still analyzing her data. So, but we believe that maybe there's element of foreign body reaction as well that could, give rise to that increase in MMP8 levels. But at this point, because the analysis is not completed yet, we cannot say that that is true. But I think, of course, when you do another reason can be as well, because when you do ELISA, there might be some, technical issues as well with the analysis. But I don't think that's the problem in this case. But at least that we have to also consider that. Perhaps I think sometimes the variations, because in between the follow-ups, there haven't been any maintenance. So patient brushing can go up and down. So they haven't got any maintenance therapy in between that interval follow-ups. So some patients might have got, might not be cleaning very well, and that's why we ended up having that high level of MMP8 at that point. And then when they come again for the appointment, when everything is up, maybe because of the Hawthorne effect or because they have seen the dentist, the motivation came back. So that's why maybe they're brushing well after that. It can happen as well. So, but we are considering all the factors at the moment. We have to analyze everything first before we can conclude.
I see. Thank you, Professor. That's a really insightful answer, and I'm waiting for the final results.
Okay.
Thank you,
We'll
Professor.
share, yeah.
Okay, thank you, Dr. Leo. And then if there's still any question?
No question? Okay.
I think it's enough. It's very clear, yeah. And then thank you, Prof. Safida.
Thank
and
you.
then please still stay here. Okay. So I give it back to the
Thank you so
Thank you
much for
very
the
much.
session for today.
So next, we would like to invite to Professor Dr. Iratanti, DDS Specialist in Prosthodontics from Universitas Indonesia, to come up to the stage to present their certificate to our distinguished speaker.
Professor Iratanti will also present the certificate and give towards the moderator, Dr. Natalina. Thank you very much, Professor Sharida and Dr. Natalina, for this insightful session. Ladies and gentlemen, please give them a warm round of applause. Our next session, we will discuss the topic Oral Frailty as an Early Warning System, Community Screening and Prevention.
We would like to welcome Dr. Melissa Diatman, DDS PhD from Universitas Indonesia as our distinguished speaker. The session will be moderated by Dr. Benso Sulijaya, DDS MDS, Perio Consultant, PhD from Universitas Indonesia.
Please welcome to the stage.
All right, so good afternoon, everyone. So we just heard a very interesting presentation. So today, me, as the moderator for Dr. Melissa, We are very excited to have Dr. Melissa here. So Dr. Melissa is my beloved senpai. So let me introduce Dr. Melissa. So Dr. Melissa is a leading expert in dental public health and preventive dentistry. And she's an associate professor at the Universitas Indonesia. Her research deeply rooted in improving public health outcomes and focused on critical areas such as reducing dental caries, assessing health impacts on children, and promoting geriatric oral care. So today she will be presenting on the concept of oral frailty, as we can see here, a condition recognized as globally as a key indicator of overall health decline in the older adults. So without further ado, let's welcome Dr. Melissa.
Thank you very much, Dr. Benso, for the introduction. Good afternoon, everyone. I hope you have a good research day today, watching all the lectures and having discussion at the poster session as well. Very welcome to all of our guests from Chulalongkorn, from University of Malaya. Thank you very much for coming to our joint symposium. So today I would like to share with you a little bit about oral frailty as an early warning system in the context of community screening and prevention. My name is Dr. Melissa from Department of Dental Public Health, Faculty of Dentistry, University of Indonesia. Can you click? Okay. It's not working. Okay. So first, in a global context, what is happening in the population in the world, we call the health transition. So health transition happens, the combination between demographic transition and epidemiological transition. So the demographic transition show you that people are now don't want to have a lot of children, so low fertility, and then the mortality rates also decline. So because of this, a lot of people live a very long life, but have low fertility. So low birth and also low death rates creates a change in the population pyramid. And also in epidemiological transition, the mortality or the cause of death changes from infectious disease to non-communicable disease. So it creates a difference in the population pyramid. So if you see in the pyramid in countries like in Japan, so it changes from triangle into inverted triangle. And recently, WHO also, usually we use life expectancy as an indicator of the health situation in a country. But now we shifted into HALE, healthy life expectancy. Indonesian people now, the life expectancy increases up to between 71 to 72 years old. But the healthy life expectancy is only 62 years old. That means elderly in Indonesia only live until 62 years old without any comorbidities. So after that, usually they have either diabetes mellitus, cardiovascular disease, so they live with different kind of comorbidities. So because of that, now globally, also in WHO indicators, healthy life expectancy is widely used because it really describes you how well a person lives within their long life. So not only how long they can live. Okay, so now we see the proportion of older people living in Southeast Asia. Thailand, the proportion of elderly is quite high, 23.7%, and Indonesia is 11.75%. But if you time that percentage with the actual population, Indonesian population is now more than 280 million, times 11%. So right now, Indonesia is the 5th country with the highest absolute number of elderly after China, India, USA, and Japan. That means all of you in your practice, in your dental practice, you will see a shift that a lot more of elderly or older patients come to take treatment in your dental clinic. So 2 months ago, Indonesia moved from Siero to WIPRO. So we say bye-bye to Thailand and we join Malaysia in Western Pacific region in the WHO section. So oral disease burden in the Western Pacific region, or WIPRO, is the most common non-communicable disease in our region, affecting more than 800 million people, or more than 40% of the total population. Specifically, 1 in 5 adults suffer from complete loss of teeth. So in that case, in WIPRO area, including Malaysia, Indonesia, Singapore, and some countries in Southeast Asia, prevalence of dental caries is high, periodontal disease also, tooth loss, xerostomia, and also oral cancer. And this will have effect in the oral function of the elderly. So why oral health really matter for older people? Number one, it relates to nutrition and frailty because declining in ability to chew and swallow can lead to undernutrition and weight loss, and also obesity. We will talk about this later. And then oral health also essential for functional and dignity. So it will affect the way the older people speak and also eat. And this will have, if they have problem when they're eating, they feel ashamed, they will cover their mouth, and they don't want to meet other people. And also, the third aspect is social connection. Poor oral health can reduce social participation and also increase loneliness. And now loneliness become a huge problem in mental health for older people. Next. So in WIPRO area, in general, for older people, there is a lack of access to affordable essential oral health care. So if you do a survey, there are a lot of older people never visit a dentist in their whole life. If you visit a survey, when you do a survey in primary healthcare, and then you will meet people who never visit a dentist, but their age is like already 67 or 70 years old. So WHO data show only 3% of the population in the region entitled to essential oral health care services. Even when we do a survey, how many people who lost their teeth and replace it with denture in Indonesia is less than 14%. Next. So what is actually oral function? Oral function is a motoric function of the oral mechanism, including the jaw, the tongue, lips, cheeks, and salivary flow for the purposes of eating, drinking, speaking, and other mouth activities. If our oral function declines, it will reduce, number one is chewing efficiency, causing nutritional deficiencies and prevent older adults from enjoying eating and communicating with each other. So why oral motor function is important? How can we see if a person of an elderly have a decline in oral function? Number one, if they sip a cup, and usually they have a spill on the edge of their mouth. So inadequate lip posture will cause labial spill when they drink. It will cause embarrassment when they eat or drink in front of other people. And then masticatory muscle, it will affect food preferences. They will choose food which have softer texture and will avoid eating fruits or vegetables. And then tongue support, you will see when they're young, they do not snore, but as they go older, they snore. And this may cause by declining in motor function. And then speech disorder, deficits in swallowing. They often choke when they eat soup or tough food. And salivary hypofunction, which will also affect the swallowing reflex and increase the microbial colonization in elderly, and also increase the risk of aspiration pneumonia. Next. Okay, so in general, oral frailty is a certain grade of decline from healthy mouth to deteriorating function. It will affect your difficulty of chewing, difficulty in swallowing, dry mouth, especially if they have fewer teeth, and also low articulatory oral motor skills. Next. So how can we measure oral frailty? So recent publications show there are two main instruments that you can use. One is oral frailty 5 and the other one is oral frailty 8. So the difference between the two, the OF5 only measure the core oral function, which is chewing, swallowing, salivary flow rate, and speech or pronunciation of words. It is very short, rapid. You can administer it like in 2 minutes, and you can train a non-dental staff to do it. So we tried to implement this screening instrument in Puskesmas or public health center. So OF5 is good when you want to use it in a community for screening or in primary healthcare setting, and it's already being widely used in Japan. Next. Okay, so we tried to use this oral frailty 5 scale in Jakarta population, and these are the findings from our Jakarta study: association between oral frailty, nutritional status, and physical frailty among older adults in Jakarta. Next. So this is a cross-sectional study. We tried to have a representative population from 6 different municipalities in Jakarta. We use a non-probability proportionate quota sampling, and we recruited 402 elderly, community-dwelling elderly, which participate in activities in public health center. So the instrument that we use is the oral frailty 5. This is a very brief one, and we categorize the subjects to have no oral frailty if their score is 0 to 1, pre-oral frailty 2 to 3, or having oral frailty if they have the score 4 to 5. Next. So what do we evaluate in OF5? The fifth question. So number 1 is, how many is your natural teeth? So we ask the patient to count using a mirror, and then, do you have any difficulties eating tough food compared to 6 months ago? Do they feel they need to change the consistency of their food? And number 3, have you choked on your tea or soup when you eat or drink? Or do you often experience having a dry mouth? And the last one is, have you have difficulties clearly pronunciation of words? So for number 5, if you want to add, there's another examination called oral diacokinesis. We ask the patient to say ta 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 words as fast as he can, and we counted how many times they can say in seconds. Next. And besides OF5, we add another instrument, which is the short form of mini nutritional assessment. This is a regular screening tool to identify elderly persons who are malnourished or at risk of malnutrition. Consists of 6 questions asking about food intake, weight loss, mobility, psychological stress, neuropsychological problem, and we count their BMI. And we categorize their score into malnourished if less than 7, at risk of malnutrition between 8 to 11, and having normal nutrition status if the score more than 12. And the third instrument is Frail Scale Questionnaire. This is also a very short screening tool for frailty older adults. And the question is focusing on fatigue, resistant, ambulation illness, and loss of weight. Recently, do you feel fatigue or difficulty in climbing only 1 step of stairs, difficulty in walking for about 1 block, having more than 5 comorbidities, and unintentional weight loss? So the result of this study is we want to see the connection between oral frailty, nutritional status, and frail scale of the elderly. So the mean age of the subject was 67, 66% are female, and surprisingly, the result of the screening tool, 57.7% is categorized having oral frailty. So you see, this is community dwelling elderly, which is the older adults are still independent. So in the independent older adults, they already, 57.7% already in the category of oral frailty. And the risk In those subjects, 46% is at risk of malnutrition, and 9.2 is malnourished. And for their frail scale, 45% are categorized as pre-frail, and 20.1% is categorized as frail. Next. And we find significant correlation between oral frailty and nutritional status, and we also find significant correlation between oral frailty and physical frailty. That means if your oral function decline, you also have, you might affect your nutritional status and your physical frailty as well. Next. Okay. Let's see the nutritional status by the instrument of mini nutritional assessment. So the BMI majority is 23. According to the Asia Pacific BMI classification, this is considered to be overweight. So you have fewer teeth, but you are overweight. And this is quite an interesting phenomenon. Next. Next. We find significant relationship, and those who have fewer teeth and no functional occlusion have the chances, increase their chances to become underweight or overweight and obese. Why is this happening? Because mechanical difficulties in chewing and also the consequences of reduced salivary flow will cause, next, inadequate chewing ability, and in elderly, it will cause altered food choice. So that older people will switch between three options. Number one is switch to soft and easily chewed foods, which is usually biscuits. So if you see your grandmother or older people in public health center, they always have biscuits in their bag or in their room. So high sugar, high trans fat, causing their weight to increase. And number two, reduced consumption of vegetables and fruits. So they switch because it's hard, it's difficult to chew, they reduce the consumption of vegetables. And the last one, they want to eat vegetables, but they overcooked it, or they use a processor, so all the vitamins and minerals are gone, they just want to have the taste. Okay, so because of this, there's a changes and limitation in their nutritional intake, and this will cause them to have either underweight or malnourished, or tendencies to be overweight or obese. Okay, so this is a very interesting cohort study by Professor Fukai from Japan. He did a 5 years cohort study comparing individuals with 20 or more teeth and then compare it with 19 teeth or fewer. And he found that in all non-communicable disease, individuals with 20 or more remaining teeth have significantly lower incidence in NCD, such as diabetes, hypertension, cancer, and everything, compared to those who have 19 teeth or fewer. So this, you can see, nutrition plays a huge role in this result. When they have more than 20 teeth, they tend to be able to eat all types of food. So this explains the pathway, how oral health and numbers of teeth and also oral function will affect nutrition and eventually affects their functional ability and affects their healthy life expectancy. So if you want to have a high healthy life expectancy, that means you have to also implement and teach your patients to keep their oral function ability and to keep as much as teeth as possible until they grow very old. Okay, so based on that Jakarta study result, how can we move forward? So how can we use this oral frailty scale to implement it in puskesmas or primary health care, and how can we recommend the policy to the stakeholders to implement this type of screening? Next. Okay, so by using a very simple instrument or simple questionnaire, we can use the OF5 checklist in puskesmas or public health center, and this can be done by health volunteer, by non-dental staff. And when they do the screening, stratify it. If someone comes with a positive result, positive of oral frailty, that means we need to combine the health advice with short nutrition and frailty check as well, and gives the clearer risk profile. And after we stratify the problem in Southeast Asia, we do screening, but there's no intervention. We only just keep the data without any impact. So the next step should be intervention, immediately provide support, either just simple oral hygiene instruction, denture care, or dry mouth management. And maybe you can also combine the program with nutrition program or aging program, talking about a healthy diet. And lastly, we have to do follow-up. For the oral frailty check, we need to reassess after 3 or 6 months whether the problem persists or even worse, or whether they need referral to geriatric services. Next. Okay, in terms of policy, at the end of COVID era, WHO already include oral health in the mandate for WHA resolution. So for the first time, we have the GoHub, Global Strategy and Action Plan for Oral Health, starting to be implemented from 2023 to 2030. And this document is implemented in all member states, so everyone needs to have a preventive program, including a program for aging population. So WHO also published what we call ICOPE framework. This framework focuses in maintaining intrinsic capacity in older people by focusing in 6 domains, which is cognition, mobility, nutrition, vision, hearing, and psychological well-being. Where is oral health in this scheme? Next. So the link with oral health, oral function like chewing, swallowing, and saliva directly influence the nutritional status, which is one of the main ICOPE domain. And then poor oral health also contributes to malnutrition, weight loss, and frailty. And xerostomia or swallowing difficulties also affect eating pleasure and reducing social interaction and mental health or mental well-being. So right now, ICOPE is a plan that WHO going to implement in community-based settings. So right now, oral health is included in the ICOPE care pathway, and later WHO will implement this to every member state and integrate this in primary health care settings. And in policy or dental public health point of view, we need to collaborate dentists, policymakers, and communities in terms of healthy aging program. So through policy advocacy, dentists can actively participate in including oral health in aging program. And community partnership, we need to collaborate with local health district, local government, NGOs, or societies in the community to integrate oral health program in healthy aging program. Next. And the second one, the policy for long-term home or institutional home for the elderly. So we need to integrate oral hygiene and essential care as a mandatory thing that needs to be done in the long-term care home. And also train the staff to be able to do early detection, either using OF5 or implementing teledentistry. And we have to do a monitoring system by checking the baseline status of the older adult and through period of time. Next. So early detection in the institutional home, we can use this very simple intraoral camera. It will cost about $100, a very cheap one. And this can be connected to the local dentist without having to transport the older people from their institutional home to the nearest public health center. Next. And also, in every primary health center, there should be basic essential oral health care, such as GIC, fluoride varnish, and sulfur-diamine fluoride, like Dr. Panida mentioned this morning. So sulfur-diamine fluoride is a very effective agent for caries arresting, and it's very effective if you use it in older people. Okay, so as a conclusion, oral frailty is an early warning system, a very simple screening tool that we can use in primary care. And then after screening, you have to stratify, intervene, and finally follow up. It will reduce disability and cost of treatment. And you can, usually if we make an oral health program by itself, it's very difficult to get a budget. But if you integrate it with nutritional program or aging program, it's easier to get budget. Okay. So at the end, I just want to acknowledge Department of Dental Public Health and Preventive Dentistry in UI, and this is Shafa Tinezia, which she done a good job in collecting the data. And next. So just want to inform you, this year we had the first ever Asian Geriatric Dentistry Conference in University of Malaya as the host. But next year, in 2026, Indonesia will be the host. So if you are interested in geriatric dentistry, please participate. And this is not only talking about public health, but also clinical aspects in geriatric dentistry. Okay, at the end, I just want to say that in dental public health, it's very difficult to able to have a national program, especially in elderly, the successful one. So whatever you have, start where you are, use what you have, and do what you can, because sustainability is not about doing everything perfectly, but it's about doing what you can consistently. Thank you very much.
Okay, so thank you very much, Dr. Melissa, for giving us a very comprehensive information related to this topic. So because we have limited time, so I would like to give only probably one question to the floor. Is there any question? Yes, can I? Okay, Mamida? Okay. So could you please raise your hand so the staff can give you the microphone? Yes, please say your name and your affiliations.
Good afternoon, Professor, doctors, and colleagues. My name is Miss Rahanum from Periodontic Department, Universitas Indonesia. Dear Dr. Melissa, thank you for the very insightful presentations. And since I'm from the government sectors, I also so interested in this oral frailty 5 questions screenings. And my question is, how far does these questionnaires ready to be implemented in Indonesia? Is there any bias since during the experiments you were doing? And yeah, we hope that someday maybe oral health will become a government priority in national health. And that's from me, Doctor. Thank you.
Thank you for a very good question, Dr. Hanum. So the OF5 question is already translated and validated in Bahasa Indonesia in our language. It's easy to implement. Just you need to have like a simple training for the non-dental staff to do it. Because for the elderly, sometimes when we ask how many teeth that you have in your mouth, if you are there, you know that that person counted correctly or not. So the bias part sometimes, because it is self-reported, so sometimes the number of teeth is not accurate, and there's an effect, what we call the bias, that they want to give a good answer. So it's not actually what they feel. So we need to make sure beforehand, before they fill out the questionnaire, make sure that no social desirability, no one will judge you, so just give the truthful answer. So to do that, we need to train the interviewer first and to make them just familiar with the item of the questionnaire. But it's actually very simple. You can do it like in 1 day. And the most important thing after implementing the questionnaire, how can we refer? If the patient is categorized as oral frailty, then what is the next step? So this is the procedure that we need to agree upon, especially in primary healthcare. Thank you.
All right, so thank you very much, Dr. Melissa. I think It's beneficial for all of us. We are looking forward to have the training probably from you. So because we as a dentist and also specialists, I think it's a good opportunity to have this knowledge and then looking forward for the training program. So thank you very much, Dr. Melissa. Give applause to Dr. Melissa.
Thank you so much. So next, we would like to invite Dr. Brahma Kiswanjaya DDS PhD from Universitas Indonesia to come up to the stage to present the certificate to our distinguished speaker. And also, we would like to invite Dr. Benzo to the stage to receive the certificate from Dr. Brahma.
Thank you very much, Dr. Melissa and Dr. Benzo, for the valuable session. Before we continue with the next session, let us take a moment to watch a short video preview of the upcoming 65 Days Natalis celebration, giving us a glimpse of the excitement and spirit that awaits.
Enjoy the movie. Okay, now we move on to the next session, which is clinical evaluations of fluoroquinolone, acetonide, and dexamethasone mouthwash in treatment of oral lichen planus.
We are honored to welcome Associate Professor Pompan Piburathanakit, DDS MS PhD from Chulalongkorn University as the speaker, with Professor Dr. Yuniardini Septorini Wimadani, MSc, then PhD, specialist in periodontics from Universitas Indonesia as the moderator.
Okay, thank you very much for the introduction. Good afternoon, ladies and gentlemen, the Dean of the Faculty of Dentistry, Universitas Indonesia, Faculty of Dentistry, Chulalongkorn University, and then Prof. Tos from University of Malaya. Very nice to see you, and I'm very honored to be one of the moderators for our first international joint symposium of Dental Research Summit in 2025. First of all, I may briefly introduce you to our speaker, Associate Professor Ponpan Pibun Ratanakit, or I should call her Professor Jeb, because we first met in oral medicine event in Bangkok several years ago, and then we share common friends. So I'm very honored to be your moderator today, Prof. Jeb. And before we start, please allow me to read a brief CV of her. She is a faculty member of Chulalongkorn University with board certification from Thai Board of Oral Diagnostic Science in Oral Medicine. She has worked on clinical practice and academic teaching in both undergraduate and postgraduate curricula in the field of oral medicine since 2004. And she encompasses the diagnosis and management of oral mucosal diseases, oral manifestation of systemic conditions, and oral facial pain. And her research focus is in oral immunopathogenesis, diagnostic approaches, therapeutic outcome of oral mucosal disease. And her talk today is entitled Clinical Evaluation of Fluocinolone Acetonide and Dexamethasone Mouthwash in the Treatment of Oral Medicine, or Oral Lichen Planus, sorry. Prof. Jeb, without further ado, please, the floor is yours. Please give big applause for Prof. Jeb.
Yeah, thank you, Dr. Eater. Yes. And good afternoon, everybody. Yeah, today it's my great honor to have opportunity to present my ongoing research. And the topic today from my presentation is clinical evaluation of fluocinolone acetonide and dexamethasone mouthwash in treatment of oral lichen planus. And you see, this is our dental school at Chulalongkorn University, and my workplace is in the high building. Yeah, that you can see the virus mirror. Yes, this is our building, and we have many building. Yes. Okay, we go next. Yeah. This is my outline of presentation today. Next, please. Yeah, introduction. Okay, oral lichen planus is a common chronic inflammatory disease of the oral cavity that affects activity of daily living in several patients. In our clinic, oral medicine clinic, there are many patients with oral lichen planus. Maybe it's the number one of oral mucosal lesion in our school. And most OLP patients were middle-aged women. And they have many chip complaints. Most of patients have burning sensation, pain, or somebody feel roughness of the mucosal surface, but some of patients no any symptom. Common location in the oral cavity of OLP, mostly in the buccal mucosa, gingiva, and tongue, and we can find to the other surface in the oral cavity too. This is a clinical subtype of OLP. We can find many subtypes of OLP in one patient. Somebody will have reticula. You can see the reticula. It's a white style, and somebody have atrophic that have erythematous area on the oral mucosa, and sometimes combined with the white style. But some people will have a papura subtype, which is you can see like the white dot on the oral mucosa, and Parktype like the white patch, and erosive and ulcerative area. And the rare subtype is Buras subtype. Actually, the reticular type always asymptomatic. But for the other types, such as atrophic and erosive ulcerative subtype, the patient will suffer with the pain or burning sensation, and very difficult to clean or to eat some spicy food like Thai food, or I think maybe Indonesian food too. Yeah, because it's a little bit spice. And next piece. For the diagnosis of OLP, usually we will use a clinical and histopathological examination. And I show you for the clinical manifestation of the patient, and for the histopathological examination, we can find like keratinized specified squamous epithelium at the top of epithelium, and we can find liquefative basal cell degeneration at the basal cell layer and band-like lymphocytic band at the subepithelial connective tissue. And in our clinic, we always let the patient have direct immunofluorescence or DIF combined with a clinical and histopathological examination. And characteristic of the DIF, as you can see that the deposition of fibrin at the basement membrane zone. And somebody will have deposition of IgM, C3, IgG, or IgA at the choroid body too. For the treatment of OLP, right now, OLP is still no curative treatment. So the aim of the OLP treatment is to relieve symptoms and inflammation. We want to relieve pain of the patient or any difficulty of the patient for the oral function, like cleaning, the oral cavity, teeth, and for the oral hygiene of the patient, and reduce the inflammation, and to reduce the risk of malignant transformation, because the OLP is one of OPMD, even it have a low incident of malignant transformations is about 1 to 2%, but we have to follow up the patient, because we have to aware and evaluate the progression of the disease. The topical corticosteroids are the mainstay treatment for the symptomatic OLP. The advantage of topical corticosteroid to treat the oral lichen planus or oral mucosal lesion, there are many advantages as follows. It can reduce pain and inflammation because it's directly contact with the lesion. And it's safe in the patient with systemic disease, and we can reduce dose of and side effect of systemic corticosteroid, especially in the patient with systemic disease. We can, it's very safe to use the topical corticosteroid, and it's easy to use, and it's have the cost effective. However, the topical corticosteroid have some disadvantage, which is we can find the pseudomembranous candidiasis and have bad taste. Somebody will come with right discursive, have some salty or change of taste, and like hyperpigmentation after treatment. The topical corticosteroids are used in various forms, like oral paste, mouthwash, and solution that depend on the clinical severity and distribution of the lesion, such as if the patient have multiple sites of lesion in the oral cavity, we will use the mouthwash because the mouthwash can spread all around the oral mucosa and can contact with the lesion. But somebody have like single lesion or the lesion not so severe, we can select for the oral paste or solution instead. Using Using corticosteroid mouthwash is especially effective. For the mouthwash, because that I mentioned is for the widespread oral lesion and the lesion that is in the side that difficult to access, like at the soft palate or the ventral tongue or some area that the patient difficult to apply the medication. This is the in-house preparation, topical corticosteroid formulation. And this all produced by Department of Pharmacology at our faculty, Chulalongkorn University. We work together with the staff with the Department of Pharmacology, and we have topical corticosteroid treatment in oral lesions maybe more than 30 years ago. The first one is the fluocinolone acetonide in solution. For fluocinolone acetonide, we will begin with the solution and some in oral base, and next we have fluocinolone acetonide plus clotrimazole gel. That you know, clotrimazole is the antifungal drug, and we combine it together. That we would like to decrease the risk of the patient to have oral candidiasis. And for the most potent one that we have in our school is clobetasol propionate in oral base. For the mouthwash formulation, right now we have 3 formulations. The first one is the dexamethasone mouthwash, diamcinolone mouthwash, and the last one that we just have for 2 or 3 years ago is the fluocinolone acetonide mouthwash. For the previous study about the mouthwash, topical corticosteroid mouthwash, that still have 2 or 3 previous study that compare between fluocinolone acetonide mouthwash and dexamethasone mouthwash. For the first one, but is different the concentration. That from this study, they found that both of medication can reduce pain and clinical score in the 6-week treatment. Anyway, no significant difference between 2 medications. And another one is compare between fluocinolone acetonide in oral base and versus dexamethasone mouthwash. And both medication also can reduce lesion size and score and pain score too. Anyway, no significant difference between groups. So the objective of our project is to compare the therapeutic efficacy between our in-house product 0.05% fluocinolone acetonide mouthwash and 0.05% dexamethasone mouthwash in the treatment of symptomatic oral lichen planus. So we'll follow up patients for 4 weeks. Next, please. Material and method. Yes, this is the inclusion criteria in my project. We will include the patient who met this criteria. The patient will have 18 years or older and have clinically and histopathologically diagnosed at OLP or compatible with OLP. And OLP size score of 3 or higher than 3 at baseline, and have NRS pain score of 3 or higher. And the patient will have like erosive, ulcerative type or atopic type, and no corticosteroid usage for at least 3 months periods to the study. And the patient have willing to comply with the study protocol. For the exclusion criteria, we will exclude the patient who have the histopathological evidence of dysphagia and have oral rachinoid lesion secondary to dental material that we just draft. This is the oral rachinoid contact lesion or GVHD, and patient with pregnant or still lactating women, and have active bacterial, fungal, or viral infection in the oral cavity, or the patient with a heavy smoking within past 6 months, or long-term use of systemic corticosteroid therapy, and uncontrolled diabetes mellitus, and who have severe dry mouth, and current use of immunosuppressant, and refuse to the follow drug prescription. We have like lots of exclusion criteria, so yeah, we are a little bit difficult to recruit the patient in the study. This is the flowchart of our study. So the patient will have diagnosed as clinically and histopathologically as OLP. We will randomize grouping into two groups of intervention, group A and group B, that is fluocinolone acetonide mouthwash and dexamethasone mouthwash. And we will have followed 2 weeks post-treatment and 4 weeks post-treatment. At the baseline visit, we will collect the information record for the socio-demographic data, pain score, and QOL, quality of life of the patient, and have oral examination to determine for the clinical severity and clinical characteristic. And then we just prescribe istabobide, so the patient or the researcher will not know that the patient get any kind of medication. So the patient will give like fluocinolone acetonide mouthwash or dexamethasone mouthwash and use 2 times per day in the morning and in the evening after meal. And for the 2-week post-treatment, the patient will come to the clinic and work collect with the pain score, clinical characteristic, and clinical severity by oral examination. And just got another medication, the same medication from the baseline, and use for another 2 weeks and come again for 4 weeks post-treatment and collect for the pain score. And this time we collect for the quality of life and have oral examination to see the clinical characteristic and clinical severity. Let me introduce for the oral lichen planus disease activity scale or OLP DAS. This is the first outcome that we use, and we use this instrument for the measure of the clinical severity. So Dr. Pasawat is my colleague in my department, and Dr. Piyaporn is my student, and me is we just do this research together to develop and validate the oral lichen planus disease activity scale. This we just published in the 2024. So for the OLP disease activity scale, there are the 3 parts. That the one is the oral lichen planus disease activity scale. For the total OLP size score, or we can call OLPSS, that you can see in the left panel. There are 13 oral sites, like leaf, labial mucosa, buccal mucosa, something. And then if the patient have the lesion in which side, we will give the score. Such as, and this for the upper right one, this is the clinical description of OLP size score that start from 0. 0 means no lesion. 1, score 1 means white lesion only, like a reticular or a white line or some pupil. And score 2, red lesion or erythematous lesion with combined less than the area 1 square centimeter without ulceration. Score 3, same as score 2, but the lesion of the erythematous lesion more than or equal 1 centimeter. And for the score 4 and 5 is for the ulcerative lesion. With the lesion less than 1 square centimeter, and 5 means the ulcerative lesion which have the more than or equal 1 square centimeter. This is the first part, and another one is OLP severity index or OLPSI. This one we will count for the erythematous score of the number of sites that have erythematous score or have OLPSS 2 or 3, and we will count for the ulcer score or OLPSS 4 to 5 score, and then give the score. The total erythematous score and answer score will pass together and we will get OLPSI. For the third pass is worst pain NRS score that you can see we will have numerical pain intensity scale, scale 0 from 10, 0 mean no pain and 10 mean worst possible pain. And combined together with the 3 pass, we will get the OLP total or OLP dash score, which range from 0 to 95 score. If the patient have more score, that means the severity have higher severity. Next. This is the example that we can, if we can see that like the lips, we will give the score 2, yeah, and for the right and left macromucosa, we will give score 5, and for the like for the example, for the tongue, you can see the right tongue, we will give the score 2, and the left tongue, we can see a small ulcer, and we give score 4, something like this. And then we count for the rest one mean erythemata score, and the blue one mean the ulcer score. We count is that how many size of erythemata area and how many size of ulcerative lesion, and then we can get total OLPSS and OLPSI score. Another outcome that we determine is for the quality of life. We will use oral impact on daily performance index or OIDP. That OIDP can measure for 3 domains. This is the physical domain, psychological domain, and also for the social domain. For the psychological domain, eating, speaking, cleaning oral cavity, and psychological domain is for the relaxing, sleep, smiling, or emotional stability, and the social domain is like working, carry out working, and social contact with the other people. So we will determine for the frequency score that called F, that have from score 0 to 5 and severity score, and then we will multiply frequency and severity score, and we will get a performance score of each activity. And total score of each performance, if we pass together, we will get the total performance score. This one also, the patient will have higher score indicated poorer oral health related quality of life. Next. We go to the result of the study. This is, from this study right now, we recruit for patients with OLP for 34 patients. Now it's ongoing in this research. For the fluocinolone FA mouthwash, we got 14 patients, and dexamethasone mouthwash 20 patients. From this graph, we can see for that both treatment groups show the similar baseline characteristic. You can see for the gender and age and duration of the lesion with no significant difference. You can see that the female have incidence of the oral lichen planus more than male, maybe like three times, and the age of the patient about the mostly is in the 30 to 60 years old and more than 60 years, and the last one is the less than 30 years. And for the durations is about less than 1 year. And this shows for the systemic condition and medication tracking in the our treatment group. You can see that on the left side is the systemic condition. Some patients have about 40% no systemic disease, And for the systemic condition, we can find the patient who have hypertension, dyslipidemia, and diabetes. Is the most three systemic condition that we can find. And for the other condition, is just like thyroid, asthma, or cardiovascular, glaucoma, and depression, just only a little bit. And for the medication taking also is the same, same version with the systemic condition. It can reflect the systemic condition. And this show for the symptom and location. For the left panel, you can see for the symptom, 100% of our patients have a burning sensation with the spicy foods or some chili spice material, and complaint for the ulceration for 60%, and almost 60% complaint about the roughness of the oral mucosa. For the location of the oral lichen planus, mostly we can find at the buccal mucosa. And the second one, gingiva and ventral tongue and dorsal tongue, we can find some region at lips, labial mucosa, floor of mouth, or soft palate. Yeah. And this slide shows that both dexamethasone mouthwash and fluocinolone acetonide mouthwash significantly reduce OLP severity. We just observe, we compare the week baseline, week 2 and week 4. Yes, you can see that total OLP for the left panel for the dexamethasone mouthwash, total OLP-SS, OLP-SI, or worst pain NRS, and total OLP-DAS reduced significantly with compared with the baseline. And for the right side for the fluocinolone acetonide mouthwash, at the week 2 and week 4, also we can find the significantly different because when the patient use this medication for 2 weeks and 4 weeks, the OLP severity reduced with the significantly too. Next please. Yeah, the time out.
Yes.
Okay, sorry. Okay, I cannot go.
No. You still have 2 to 3 minutes.
Okay, yeah, I will just a little bit speed. Okay, but anyway, we cannot find any significant difference between group, between dexamethasone and fluocinolone mouthwash. Next, please. This is the improvement severity after treatment with the fluocinolone acetonide mouthwash. You can see upper panel, week 0, week 2, and week 3. You can see like the severity and the oral region just appear a lot. And for the next one is for the dexamethasone mouthwash. The next one, yeah. This one a little bit difficult to see because of the color, but anyway, we can see that dexamethasone can effectively well with the oral lichen planus. And the next one, we go to the quality of life. We can see that the number of OLP patients with oral impact on daily activity will decrease after 4-week treatment with both medication. So we can see for the eating, cleaning oral cavity, and emotional stability is a top T. Yeah, it's the same fraction between dexamethasone and fluocinolone mouthwash. Yeah, this one is also a severity score of the quality of life. It's the same fraction with the number of the patients who suffer with the daily activity. Yeah, please, next. Yeah, we go to the discussion. Maybe we can skip this part, yeah. Okay, we go to the next one, Okay, So yeah, this one is my study for the clinical side or around lichen planus, and we just use the Thai version of OIDP that in this two paper can find with the consistent with the this study. Okay, go the next one. So for the conclusion, we can conclude that both fluocinolone acetonide mouthwash and dexamethasone mouthwash are effective first-line topical therapy for symptomatic OLP because it can reduce clinical severity and pain intensity, and it can improve quality of life, including eating, cleaning the oral cavity, and emotional stability. Anyway, in this RCT, we cannot find any difference between two medications. I would like to acknowledge, for the committee of the UI Joint Symposium for the very excellent organizing this symposium. Dean Ponchai and Faculty of Dentistry, Chulalongkorn University. Dr. Pani Park is my student to the main contributor in this research, and Associate Professor Orana, which is contributes in this research too, and my staff in oral medicine and my postgraduate student. And these studies we get a grant from the Faculty of Dentistry and Royal College of Dental Surgeons of Thailand grants. Thank you very much for your attention.
Thank you very much. Give round of applause for Prof. Jeff. All right.
Thank you.
We still have one question. Yeah. We still have time for just one question from the audience. Are there any questions? No questions? Okay, there's one question there from Dr. Masita.
Hello, doctor. Thank you very much for the time, Prof. Ita. My name is Masita from the Oral Medicine Department. My question is that you use two kinds of mouthwash, the fluocinolone and also the dexamethasone. So they are both steroid mouthwash, right? For clinical application, maybe can you again repeat which one do you prefer, or maybe you have a preference, like you use dexamethasone for cases of OLP in erosive, or maybe the fluocinolone for reticular case. Is there preference in it? Okay, thank you.
Okay, thank you for your question. It's a very good question. Yeah, in our clinic, we have many kinds of medicine, but for the mouthwash, we have three kinds. Actually, if the patient have a lot of pain, I mean that NIS score like 9 or moderate or severe pain, or in the patient who have wide space and have ulceration, loss of ulceration area or erythematous area, we will choose the potent one. The super potent one is fluocinolone acetonide mouthwash first, and if the patient just like the symptom relief, and then we can change the medication to triamcinolone mouthwash or dexamethasone mouthwash, or also we can adjust for the frequency of the topical steroid mouthwash too. Or sometimes we can combine with the mouthwash and oral base in some area of the lesion. Thank you.
Thank you so much for the answer, Prof. Jeb. I think it's time for the session to finish. Thank you so much for the insightful talk, Dr. Jeb, Prof. Jeb. I believe that lichen planus is very challenging condition, chronic condition that is very challenging both for clinician and for the patients to treat and to have it. Okay, so please give big applause for Prof. Jeff for the very nice presentation, and I give back the session to the MC. Thank you.
Okay, thank you so much. So next we would like to invite Professor Lisa Rinanda Amir, the Dean of the Faculty of Dentistry, Universitas Indonesia, to come up to the stage to present the certificate to our distinguished speaker.
We would also like to invite Professor Dr. Yuniadini Septorini Wimardani, MSc then PhD, specialist in oral medicine, to receive the certificate and gifts from Professor Lisa Amir. And now, for our final scientific session of the day, the topic is Integrating Digital Restorative Dentistry into Clinical Teaching, Advancing Education and Research in Oral Science.
We would like to welcome Dr. Anas Hakimi Ahmad Ubaidillah, BDS, M.Clin.Dent in Restorative and Conservative Dentistry from Universitas Malaya as our distinguished speaker. And also the session will be moderated by Dr. Citra Kusumasari, DDS, Specialist in Conservative Dentistry, Consultant in Restorations, PhD from Universitas Indonesia.
Please welcome to the stage.
Thank you for the moderator, the MC. Good afternoon, everyone. I hope you are still energized and enthusiastic. Even though we have now reached the final session lecture of today's International Joint Symposium 2025, it has truly been a day full of valuable insight and engaging discussion. Allow me to introduce myself. My name is Citra, and I have the pleasure of being your moderator, Dr. Anas, for this last session. Okay, now let's move on to our final, but certainly not least important presentation. We are honored to welcome Dr. Anas Hakimi, who will be sharing his expertise on integrating digital restorative dentistry into clinical teaching, advancing education and research in oral science. Before we start, allow me to present a brief profile of our speaker. Dr. Anas is from Department of Restorative Dentistry, Faculty of Dentistry, University Malaya, and he has academic qualification from Restorative Dentistry from University Malaya and Bachelor of Dental Surgery from University Malaya. So without further ado, please join me in welcoming Dr. Anas.
Thank you, Madam Moderator. So before I start my lecture, I would like to congratulate University Indonesia for organizing this nice symposium and able to gather panels from University of Chulalongkorn, panels from University of Malaya, and all the students and also postgraduates. So give a warm clap of hands to the University of Indonesia. So I'm here to talk about how our faculty and how my department integrating digital dentistry, specifically digital workflow to our dental education, both to undergraduates and also postgraduates. Because with the recent advancement in technology, people are talking about industrial revolutions, people are talking about AI, so we need to follow what the technologies brings us and not what the technologies control us. So a bit of disclaimer, so I will show a bit of brands, a bit of companies, but we are not really tied to all the companies. Like what Prof. Firdaus has mentioned, we are open. We welcome all the sponsors, all the collaborations from industries for the benefit of our students, for the benefit of our patients, and also for the benefits of our faculty to give the best to everyone. So this is my lecture content. So I will tell you my experience converting from conventional workflow to a digital workflow, and it is not easy in terms of integrating the workflow, in terms of purchasing the equipment, in terms of letting all the faculty members, letting all the technicians together in changing from conventional to digital. And also a bit of research, ongoing research, and also what the future holds. So when I'm doing my master's, this is what I still do. Wax up on models, conventional things. So I stayed in lab up until 6 o'clock, 7 o'clock, or 8 o'clock at night to finish up all the lab procedures before doing clinical procedures to the patients, planning the treatment plan, and it's all dirty works. So this is what happened back then, probably 5 to 10 years. So now all we can see is like this. It's nice, it's not dirty, but it comes with very steep learning curve, I would say, and also money, funding. So let's look at this situation. I have graduated. Now, suddenly, in my clinic, I have intraoral scanners. So I feel like, what? This is good, right? We are following the trend of technology because we have this intraoral scanners, and also we probably have printers or milling machines. So I feel great. So because I have everything in my hands, like everything you can do on your phone, you can do in clinic as well, all the technologies. So I feel great, but trapped in the temptation trap. Because why? Most of the cases, earlier cases, when I integrating digital workflow, comes with failure. For example, open margin. For example, the surgical guide for my implant is not sitting. So it's a lot of haywire. So this is my experience at the earlier integrations of digital workflow. So rather than we control the technologies, now it's like an alien and predator, they control us. So it should be other way around, right? Okay? So that's why I go search to the experts, and also this is the simplified what are the digital dentistry workflow is all about. The first one is the data acquisitions. So the data acquisition is easy from the clinic. We do CBCT to get the DICOM files, and currently we also do face scan to integrate all the data together. Then we put it into the software so that we can manipulate it. We can design it into CAD/CAM software. So we have a lot of things, a lot of software that can assist us in treatment planning. And then before CAD, we need to verify our planning. So we sometimes call back patients, and we make sure that our planning in the software is correct. And then we go to the CAM. Either we do addition, 3D printing, subtraction, milling, and review it before we finalize the treatment procedure. But this is in conjunction with what, if you heard this, Chris Kochman, if you're familiar with digital smile design. So he also put digital workflow in 6 steps. So the first one is patient digitalization, which is data acquisition, taking all the data from the patients, regardless whether it is in STL files, whether it is DICOM files or face scan. Then they put it in the software, planning it, and then they call back the patients in the clinic to sort of like confirm what they have been planning in the software. And also they execute the treatment plan. So from this, what I can see in the earlier integrations, rather than institutions controlling the digital dentistry workflow to the clinical setting, most of the time the industry control it. So I think it's best for us the education comes from the institution rather than the industrial. Yes, they can help us, but we need to lay down the proper curriculum, for example, so that it is not that far off, so that the industry can also collaborate with us then to make a good curriculum. So that's why this is what role of institutions and dental schools in this digital dentistry. So we are talking a lot of immersive learning pedagogy. We're talking a lot of digitalizations. We are also talking about role of AI in dental educations. So in Malaysia, our Malaysian Dental Council has revised the curriculum for both undergraduates and also postgraduates. For undergraduates, they include one of the program learning outcome, One of it is to manage digital and numeracy information skills in field of dentistry. So the purpose of this is to let the undergraduates at least know what is happening outside, which is digital dentistry, and also for the specialties, for the postgraduates, they're also inserting one of the program learning outcomes. One of it is able to select suitable digital and analytical tool techniques to resolve problems. So that's why we put out open policy whereby all the suppliers, all the collaborators, all the industry can come into the faculty and help us in terms of this. So we kind of like review our curriculum repeatedly to abide with this new program learning outcome by our councils. So next is role of University Malaya itself. Now our university are talking of a lot of integrations of AI, integrations of immersive pedagogy digitally, and also our faculty also need to abide with all the councils and also all the University Malaya policy to have a good facilities, to get a good equipment to abide with all these new up and coming policies. So that's why we need to have a good equipment, a good software, a good training, not to the student, a good training to the lecturers, a good training to the technicians, and also collaborations with industries. So this is what we have currently, what we try to equip one by one. So it's not easy because it takes so much time, it takes so much funding to get this, and also we able to collaborate between a lot of suppliers, a lot of industries to get equipped with digital dentistry workflow equipment. So the first one that we think we need to equip is, this is back then 5 to 7 years, we equip our technician first. So we buy our tabletop scanners, softwares, milling machine, and also furnace. So earlier in the lectures, I told you the learning curve is steep, right? So our technician takes about 3 to 5 years to familiarize with this system. So it is not easy because we urge them to use this because they are so used to the conventional system, lost wax, casting and all. So they are very difficult to change to this new workflow. So after that, we get this 3D printer. So it takes a time, it takes a while as well for them to get familiarized, but thankfully now it is full in use. Then we try, there's a bit of video, then we try to get a good clinical workflow as well. So with time, probably I'll let you watch this video first. So this is what we have currently in our lab setup, with all the milling machines, the softwares. So the software is not limited to fixed processes. We also have removable splints and etc. So next is to equip our clinic with intraoral scanners, because as what this researcher Tim Joda said, the driving force in large adoption of digital restorative dentistry is intraoral scanners. For my opinion, this is the minimum. If you want to start, if you are stuck with budget, if you're stuck with funding, the first thing that you can do is to get equipped with intraoral scanners. Because you can always outsource the lab, the digital flow for the lab for outside. For you as a clinic, so this is the minimum setup to get into digital dentistry workflow. So we get all these intraoral scanners, and with all those we can change from conventional workflow at the top and to hybrid workflow. Means that some of it we still do conventional and some of it we can do digital. But with the intraoral scanners now, we have a lot of workflows. So we have conventional, we have hybrid, and we have fully digital. To such extent, we also offer single visit prosthesis workflow, whereby patients that don't have time to wait for their prosthesis, or even if you read about minimalist dentistry, adhesive dentistry, we can make full use of this because we can use lithium disilicate, we can use zirconia, we can use composite. It's all range of processes that we can do with this single visit without temporizations. So it is highly in demand, especially for the VIPs, especially for patients that have no time to wait for 2 to 3 weeks for their prosthesis. So this is the setup that we have. So it is in a postgraduate clinic, restorative clinic, so they can use it. So this has a learning curve as well, because sometimes you need help of the technician to get the milling done, to get the processes into the furnace and all. And sometimes the most difficult thing is staining, because there's a learning curve as well. Other than that, it's all automated. Okay, we also have workflow for the removable processes as well because of the equipment that we have. So rather than we do the lost wax technique, we also have a digital workflow whereby we can scan the impressions or we can scan directly from patient's mouth. So with all that, we can look at the adoption of digital restorative dentistry. So again, the adoption of the driving force in the large adoption of digital restorative dentistry, it depends on the intraoral scanners. That's the first thing. And then from this study, most of the things that benefit patients and also clinicians is the clinical time efficiency and also simplification of laboratory process. That's the most two important things that they get from this changing to from conventional to digital workflow. And also, if you look at the implant supported restorations, they shorten the time to plan and they shorten the visits. They minimize the visits of patients to clinic to get the treatment done. So if you look at this, most of the adoptions of the digital workflow currently in Europe is more towards the implant-supported single unit because they can plan it to the digital implant software and they can print the surgical guide. So after all this, we have equipped with all the equipment, we have equipped, we have well-trained lecturers, we have well-trained students. What I can see from my observation in 2024 alone, we can reduce about 20 to 30% of purchasing impression materials, even to such an extent, finally we have impression material that expired in our stock. So that's not happening for the last 5 to 10 years. So rough estimate is about 40 to 60K ringgit Malaysia in 2024 alone. The reducing of the funding on the impression material because we purchased the impression, the intraoral scanner. And also the turnover time. So our laboratory to clinician cases is faster, especially for fixed processes, single unit monolithic. So from 2 weeks to 1 week, and sometimes to such an extent, especially for students, our undergraduate students, chasing their requirements, even the technician can do it overnight to such an extent, because of this digital restorative, digital dentistry workflow. So it benefits the student as well because they want to graduate chasing requirements. So how we integrate digital dentistry workflow to the dental education after we equip all this equipment? First to our undergraduates. So we initially introduced this to year 2 when they are doing preclinical. So we bring this group of students to clinic and we kind of give a demo on how digital dentistry is used in clinical setup before they go to the clinic. And also, we also have a demo for haptic handpiece simulation as well for the year 2 for the past years. And also for the postgraduates, they can do everything under the field. So they can do intraoral scanners in clinical setting. They can do digital implant planning software and surgical guide fabrications. They also can do lab fabrication as well in these hybrids and also digital workflow. And we also send them to training and hands-on workshop, and also external collaboration, whereby we call all the suppliers, all the industries to our faculty to train them on how to use all the digital workflow. Even we give chance to our undergraduates, final year undergraduates, to use all those intraoral scanners, and also to work with the technician to get their prosthesis done, so they can get a hands-on before they get out from the faculty or graduate from the faculty. So we want the educations come from our institution rather than they get it outside from the industries. So that's our main purpose here. So this is all undergraduates, final year. They are doing last cases. So under supervision, they are having, they can do all the digital workflow processes under supervision. So they like it, and it seems like they don't want to do impressions. That's what their feedback is. So from this, what are research potential and collaborations? So I have one undergraduate student currently completing the studies on exploring clinical undergraduate students' knowledge, awareness, and perceptions of digital dentistry education in Malaysia. So it is a nationwide survey. So the purpose of this is to develop effective educational strategies and curriculum structuring that will enhance the competency and readiness of future dental professionals in Malaysia, and how current dental education can adapt to integrate digital workflow. So from one of the questionnaires, aside from your learning association, what other sources have you utilized to gain knowledge about digital dentistry? Surprisingly, most of the answers from the questionnaire comes from the institution that they are learning with, mostly from the conferences and also from the suppliers and also industries. This is what we want to change, because that's why we want to integrate the digital education into our programs. So we also have a few studies, digital workflow on dental materials, intraoral scanners, and also probably in the future we can do some sort of health economic and also lay down a new digital dentistry educations in the curriculum. So with all this, I understand that the barriers and limitation is there, especially about the cost, high initial cost and maintenance of acquiring the digital equipment and software. The things that we need to aware of is not only purchasing the equipment, but also maintaining it. The cost of maintaining it, especially in updating the software, is not cheap, because sometimes it can come about 20 to 30,000 ringgit Malaysia, is about what, 5,000 to 6,000 to 7,000 USD per year sometimes for per software. Even steep learning curve, especially for dental technicians, because they are so used to the conventional workflow, it is hard to change to the digital workflow unless we send them for training. We kind of like forcing them to use all this equipment. So what's next? So it's either what's next or we are falling behind. So I know most of the center has a face scan, regardless of what brands, to include in the treatment planning, especially if you deal with aesthetic cases for anterior teeth or even full arch implant. So you can get a good treatment planning for the cases. So this is what we planning in the future, probably to equip with face scan, so that our students and also our lecturers can use this in the clinic, and also probably research potential. Even jaw motion detector, that's our future planning. So with that, we also have established fellowship of digital restorative dentistry, whereby specialists can get attached with us for 1 year and get a fellowship of digital restorative dentistry, and also fellowship of implantology. And we also have established a certified professional in digital restorative dentistry. So this is actually for dental technicians, because we know the hardest part is to get the dental technicians in the field as well, get the dental technician to know the digital workflow as well. That's why with the collaboration of University Malaya Center of Continuing Education and our faculty, we have established this one, and we will have a first intake next year in March and June, March to August. Why March to August? Because this is the peak season whereby undergrads will chase their requirements. So with that, the dental technicians can work with our current dental technicians and also can work with our current postgraduates and also can work with our lecturers. Means that they can do everything, every case that we have in our faculty. So it is a full-time courses, and we have industry standing with collaborators even overseas from China, from Europe as well, that comes in and do the workshop and hands-on during the program. So this is a program overview. So if you have interest to send your dental technician to our faculty, then you can contact the contact here or contact me. So this is my last slide. I'll leave you with this quote. A first-class ticket can't fix a wrong itinerary. Please get the information and planning right, and then fly. So don't let the technology control us, let us control the technology. With that, I end my lecture.
Wow, thank you very much, Dr. Anas, for your interesting presentation. So I would like to open the question and answer session, but maybe only one question. Okay, please, Dr. Tata.
Thank you for insightful lecture. Okay, my name is Natasha. I want to ask about, we know that we as a dentist doesn't have basic knowledge about digital technology, and how we understand fully about the technology that we don't ever know about the technology itself. Suddenly we facing the various digital tools, and then we have to choose the best, but we don't understand fully about the how the tools is work and so on. Is the University Malaya give the maybe subject about the technology itself, or specific to the tools in dentistry? This is the first. And the second, will the digital dentistry, especially in restorative field, will replace the analog protocol, just like now resin composite replacing amalgam? Maybe how important we understand the digital technology now, because nowadays we very dependent to adhesive rather than amalgam itself. So will it be same with digital technology or not? Okay, thank you.
Okay, thank you for your question. I will answer the first questions. So before we want to use it, we need to understand what are the equipment that we purchase. So let me give you an example. Let's say you get an intraoral scanner. So I believe most of the dental education, most of the dental curriculum, there's no like specific subject in teaching how the digital impression is working. The information comes from the collaborators or from the industries. So what I did at first is I get close with the industries and I ask what are the how the mechanism of work, for example, for that certain intraoral scanners, because one intraoral scanners from one to another is different. So first you need to know the mechanism of how they work, and then you understand it, then you teach to the student. That's why my first research that I showed you just now is to lay down what are the conditions now and to create a curriculum, specific curriculum in this digital dentistry to the undergraduates and also postgraduates, because now it's like show, tell and do. It's like demo and tell how you do it, and then you can do it. And our future planning is probably to get a formal curriculum on this digital dentistry in the education of both undergraduates and also postgraduates. So this is why our unit, University Malaya Dental Education Department want to lay down on, because of our council's changing of the program learning outcome. So we want to get this formalized. To answer the second questions, I don't think digital can totally replace conventionals, because I still use conventionals. I still like doing casting. I still like issuing porcelain fused metal, because that's a gold standard. So I don't think it will replace the conventional workflow in the near future, but it will speed up the process. It will help in terms of, for example, you can do hybrid workflow. So you can't really pour impressions, taking impressions, pour impression, you can scan it and then go to casting. For example, cobalt chromium, we don't really like take the impressions, we can scan it straight away. Or you can scan the impression and planning it in the software. So I don't think it will replace it in the near future, but the basic is still conventional, regardless what treatment that you have, even up to full arch implant. It's still the basic is conventional.
Thank you so much, Dr. Anas, because of the time of very limit. So I would like to give back to the MC. Thank you so much.
Okay, thank you so much. So next, we would like to invite Prof. Chai to come up to the stage to present the certificate to our distinguished speakers.
And now, we would like to invite Dr. Chitra Kusumasari, DDS Specialist in Conservative Dentistry, to come up to the stage and receive the certificates as well as the gifts.
Thank you very much, Dr. Anas and also Dr. Chitra, for this final session filled with valuable insights. Just a quick announcement, the snacks and also refreshment for our coffee break are ready and waiting for you on level 2.
Ladies and gentlemen, we have now come to the awarding ceremony of the 9th International Workshop on Dental Research 2025. This is the moment where we celebrate the hard work, creativity, and excellence of our participants.
Before announcing the winners, it is our honor to first introduce the judges who have contributed their expertise in evaluating their submissions.
For the research and innovation and startup categories, our distinguished judges are Dr. Atik Ramadhani, PhD, Dr. Vera Julia, DDS Oral and Maxillofacial Surgeon, Mr. Sunarso, SSI, MSc, PhD.
Thank you to our judges for their dedication and also careful evaluation.
We would like to invite Dr. Atik Ramadhani to please come up to the stage in order to give out the handing out ceremonies later on. Let us begin by recognizing outstanding achievements in the research and innovation category. We congratulate Elena Vian.
Please give attention. Okay, once again, give big applause to Elena Vianney.
And congrats on winning the research and innovation category.
Okay, maybe Alan, you can step closer in the middle for photos.
May we kindly ask the winner for the startup category as well as the research and innovation group to stay on the stage. For Ellen, we could just stay in here first.
Okay, now we move on to the startup category, a celebration of creativity, bold ideas, and also entrepreneurial spirit.
In third place, we congratulate Anelia Rufaida, Freja Azkar, Rania Arov, and Karen Josephine Darwis for the third winner of the startup category. We would like to invite Dr. Benso Sulijaya to present up the awards towards the third winner for this category.
Okay, maybe you can step closer to the middle for the photo. Okay, now in second place, we congratulate Rian Aditya Widodo, Semi Ahmad Haidar, Kristal An Santoso, and Muhammad Irfan Mumtaz Nur. Okay, maybe all of them, you guys can step up on the stage for the photo and receiving the gifts, also the certificate.
For the second winner of the startup category, the gifts and certificates will be presented by Dr. Benso Sulijaya. And finally, the moment that we've been waiting for. The first place for the startup category goes to Safira Gracela Putri Hernando and Siti Vanessa Najla Samara. We would like to invite Dr. Atik to please come up to the stage and receive this reward. Congratulations, Safira and Siti, for winning the first category of the startup category.
Okay, so for other winners, you guys can gather in the middle for the group photo, along with the Dr. Atik and also Dr. Benso.
Once again, congratulations everyone for winning the research and innovation as well as the startup category. You may now please return to your seats.
Okay, now we move on to the poster research session. For this session, our judges are Professor Dr. Sri Lelayati SU, Specialist Periodontics, Dr. Indriasti Indahwardani DDS, Dr. Brahma Kiswanjaya DDS PhD.
Thank you to our judge for their dedication and careful evaluation. Next, we recognize the excellence in the research category, celebrating rigorous scientific inquiry and meaningful contributions to the dental knowledge. In third place, we congratulate Maudina Heriasti. We would like to invite Dr. Brahma to present the award for this category. Okay, so maybe while Dr. Maudina is still not here, it can be diwakilkan oleh seseorang lainnya mungkin?
Maybe one of the friends can be representatives. Or maybe Prof. Lisa, yeah, you can step on the stage for your representative. Okay, maybe Prof. Lisa and also Dr. Brahma, you can step in the middle for the photo. Okay, congratulations. And also in second place, we congratulate Muhyiddin Salihu Farooq from University of Malaya.
Congratulations for winning the second place for the research category. Please for the winners to remains on the stage for photo session later on. And in first place for the research category, we congratulate Dodi Valentino Tambun.
Congratulations once again for all the winners. Maybe for Dodi can step up on the stage.
For the first winner of the research category, it will be presented by Dr. Brahma. May we kindly ask all the winners of the research category to remain on stage for a group photo later on together with the other categories.
Okay, now next, turn to the case report category, which highlights clinical excellence and the importance of real-world problem solving. In third place, we congratulate Amanda Sawitri from Universitas Indonesia.
Maybe it can be diwakilkan dulu dari teman-temannya mungkin atau okay. Once again, give a round of applause to Amanda Sawitri, the third winner of Case Report category. In second place, we congratulate Angela Putri Bunga Senanda. The second winner of the case report category will be handed out the certificate by Dr. Brahma.
Okay, congratulations. And now, in first place, we congratulate Natra Ahmad Fuad from Universitas Malaya. Okay, maybe one of the representatives can head out to the stage for giving the certificate, also the gifts. Okay, so for all the winners, you guys can step out in the middle for group photos.
And finally, we celebrate the winners of the literature review category, recognizing the critical roles of synthesis, analysis, and academic reflection in advancing dental science. Please remain on the stage first. We still have one more category for this later. Okay. In third place, we congratulate Rahman Wayudi. We would like to invite Dr. Asti to come up onto the stage and hand out the certificate for this category.
Okay, in second place, we congratulate Aulia Rizky.
Congratulations for Aulia Rizky for winning the second winner of the literature review category. May we kindly prepare for the first place winner, the things that we'll be waiting for. We congratulate Pani Martin Anugrah.
Please step up on the stage for receiving the certificate, also the gifts from Dok Asti.
Okay, maybe for this category, for the poster category, we'd like to invite Dr. Brahma and Dr. Asti to take pictures with all of the winners in here. Once again, congratulations for everyone who had won for this category.
Your hard work, innovations, and commitment to advancing dental science are truly inspiring. Let us give one more big round of applause to all our winners.
Thank you very much. With that, the Dental Research Summit 2025 International Joint Symposium has officially come to a close.
On behalf of the organizing committee, we would like to extend our deepest gratitude to all distinguished speakers, moderators, participants, and sponsors for making this event a success.
We wish you continued success in your research and collaborations. Have a pleasant evening and see you at the next symposium.
Thank you very much.